ABC Listen. Podcasts, radio, news, music and more.
You're a big fan of the Mediterranean diet, aren't you, Norman? That's not a secret.
It's not a secret, and if we were on What's That Rash, a loud bell would be ringing right now.
I need to buy this bell. What do you love about the Mediterranean diet? What's the benefit for you?
At its core, I feel better when I'm eating more vegetables in my diet than not. And I might have spoken this to you before, but you go through periods where just you let things go, you eat a crap diet, you eat too many barbecues, and I just feel gluggy and yucky.
Yes.
And then when I eliminate meat from my diet for a while, or really get it down to very, very low levels and eat heaps of vegetables cooked in olive oil, I feel great. I really feel good.
I agree with you. The more rainbows I eat, the more I sleep, the more I move.
By rainbows, you mean the different colours of vegetables?
Yeah, the fruit and the veggies, all the rainbows, good for your gut microbiome. But I feel better too, and I think we often focus on the physical stuff when it comes to what we eat. But in fact, it also impacts our mood. And there's some research suggesting that what we eat may be able to actually prevent and treat symptoms in depression.
Which is what's coming up here on the Health Report. I'm Norman Swan of Gadigal Land.
And I'm Priya Alexander on Wurundjeri Land.
Also on the show, thousands of doctors in New South Wales have gone on strike, but in the ACT, 6 orthopaedic surgeons in the public system have resigned. We'll talk about why.
Calcium scoring for heart disease risk. It's a very hot topic, but who should actually consider getting the test done?
Yeah, pretty controversial. What you need to know if you're about to get a joint replacement, or in fact if you've had one in the past, particularly if it's made of metal.
So let's start with New South Wales, because New South Wales, when it comes to health professionals, seems like a fairly unhappy place at the moment. We've had psychiatrists, which we spoke about on the show earlier this year. Now there are more than 5,000 doctors from 32 public hospitals in New South Wales who at the time of recording are on strike, a 3-day strike. And they're looking for a 30% pay rise because they are paid much less than counterparts in other states.
But it has been typified as that's all it's about, is money.
It's not about money. That's, one thing is they'd like to be on parity with other states. And they've actually put into the negotiation that they would like a 10-hour break between shifts, because there are reports of health professionals doing back-to-back 16-hour shifts, not having adequate breaks. There's talk about the brain drain in New South Wales, that a lot of public hospital doctors are leaving the state, going to work in other places, Queensland, Victoria, because they are paid better and they also have better work hours. And so with this brain drain, there's a workforce shortage.
Which makes the shift work even more pressing.
It's even worse. So you're working harder, you're being paid less. Burnout is a serious problem. And at the crux of all of this is patient safety.
Yeah. I mean, in the old days, and it was terrible. I mean, when I was a resident, my surgical job in London, once every couple of weeks, I would go on duty on a Wednesday morning, and I'd be on until the Monday night. And during that period, there would be 48 hours of what's called take. In other words, we'd be on emergency call, 48 hours during that period of time. And I remember one Monday evening, we made a serious error with one patient. We're still lives with you now. I can still remember it, because so unsafe when you work those hours. So it's not just, the poor wee souls are, we're complaining about working 16 hours. And what you'll find is the older doctors will say, well, in our day, they'll tell stories like I've just told.
Yes.
But in our day, it was dangerous. And it's dangerous now too. So patients suffer.
Patients do suffer. I have similar thoughts, of when I was a intern in the public system in South Australia. I remember being the orthopaedic intern and doing these 16-hour shifts, not putting my overtime down because we were told it will not be paid. You just didn't put it down on the timesheet. You would go home for a short period of time, try and recover, fill the cup and come back. And it is exhausting and you are bone tired and you do make errors. I remember prescribing the wrong medication that a nurse picked up. But at the crux of this is patient safety, which is a problem. And all of this happening in New South Wales is also in the context of, in March this year, there's been a landmark $175 million settlement agreed upon with the Victorian Government and Hospital Doctors Union in Victoria, where I work, paying unpaid overtime to these doctors when they were working in public hospitals. There is a culture problem within medicine. We're now starting to talk about it more. This is the first time I've actually seen doctors strike and really say we are calling for better work conditions. We need the shortage to be addressed. We don't want to be burnt out. We do want to have adequate breaks and paid the same as colleagues in other states.
What we're talking about here is often doctors who are either first year out, second year out, or maybe in third year out. But in some specialties, when you start to specialise in a particular specialty, particularly a surgical specialty, you might be the only registrar on for the hospital because there aren't a lot of registrars, in which case you're on what they used to call a one-on-one. You're on call all the time.
Yes, exhausting stuff.
Our public hospitals do great work, but it's thanks to, nurses do the hard work too. It's just everybody's under stress. And when it's not recognised, it's made even worse.
There are many, many cogs in the machine and they all need to be valued and well rested, but it is a very complex topic. And I think this is really the health profession, the doctors calling out for a real culture shift.
Let's move on to an important drug for severe acne called isotretinoin, but it's not a straightforward drug to use. And in some ways, the Therapeutic Goods Administration, who monitor safety of medications, seem to be making it more difficult.
It's become a bit more complex, you're right. They've updated the safety warnings for this medication, advising doctors to conduct a mental health assessment before prescribing it. What the TGA has said is that they've concluded that an association between isotretinoin and psychiatric disorders could not be ruled out. There's no clear causal link.
So things like depression.
Yes, and whilst there's no very clear, robust evidence, Norman, that actually this medication causes these mood changes, they're saying that there may be something there, but it leaves it very grey because as a GP, I can't prescribe this medication. I have to refer a patient to a dermatologist where they undergo assessment, often some blood investigations, and then they're given the drug.
But the problem here is you could be depressed because you've got acne.
Yes, and it's very hard to know what the TGA means here when they use this association term, because are they implying causality between the medication and psychiatric disorders when there's not much evidence to suggest that? What are they actually saying is the risk here? Am I screening patients in my consulting room and saying, go and chat to the dermatologist for more? Or am I meant to make the call and say, look, I don't think that you would be suitable for this medication because of what the TGA has said? And it just leaves it very grey. And this is already a very grey and complex area.
And with all due respect to dermatologists, they probably lost whatever mental health skills they had a long time ago.
Yeah, well, it's not their subspecialty, whereas we do a lot of it. And so that's a lot of the debate here. Who's doing the screening? Is it the GP or the derm?
So the question then is, if you're a parent with an adolescent child who's got severe acne...
Or an adult. Adults get it too, Norman.
True, but you really got to get it early to stop the scarring, don't you?
Ideally, yes. It's to prevent scarring and severe cystic disease. But, adults often use this as well. And I think acknowledging very clearly that acne in itself can be associated with psychological consequences. It can be really debilitating.
And so if you really want to have the drug and you've got to have a mental health assessment, you could lie to your doctor.
You could, but we prefer that you don't. Tell us the truth always, please.
Well, the question is what happens when you find an issue.
That's right.
So a little bit open-ended there. We might ask the TGA for some clarification and come back to you next week on that. On Radio National, you're with the Health Report. This is your favourite story of the day here, isn't it, Priya? Your food and your mood.
So I think, as I alluded to at the start, I think we often talk about the physical benefits of food and we talk about it in terms of heart disease risk and bowel cancer risk, but what we eat can impact our brain and our mood. And in fact, there's research been published in the Australian-New Zealand Journal of Psychiatry, which has found that if people adhere to certain diets, like your favourite, the Mediterranean diet and other diets, and the DASH diet, it can actually help to treat the symptoms of depression. And that's pretty amazing. Now, this isn't in the absence of psychological interventions or other lifestyle interventions or medication. But as a GP who does a lot in this space, I find this quite exciting, which is what else can we prescribe patients that they can do at home that may potentially benefit their mood? So I asked Felice Jacka, who's Distinguished Professor of Nutritional Psychiatry, founder and director of the Food and Mood Centre at Deakin University, to find out more. And we were joined by Dr. Tetiana Rox, who's a dietitian and lead of the Food and Mood Academy.
The Mediterranean style diet is the diet that's been studied the most, so that's where most of the evidence is, of course. But we also know that traditional diets around the world, whether they're, Brazilian or Norwegian or Japanese, higher adherence to those traditional dietary patterns are associated with a dramatically reduced risk in developing depression, about 35%. And also Mediterranean-style diets have been used to treat even very severe depression. But when we say Mediterranean style, it's not like you have to adhere to a very particular diet. It's more around whole foods, real foods, and avoiding the ultra-processed foods.
You've said whole foods, ultra-processed foods. Can we just give people what this actually looks like? So I actually had an endocrinologist recently say to me, they used corn as the example and said, eating corn off the cob is ideal, and then having, some sort of corn flake is actually ultra-processed. It's been processed. So you're saying people should ideally be reaching for that whole food. What's the kind of key takeaway for people there?
So when you look at food and the way they categorise ultra-processed food, this is really confusing for people, and I think we get hung up on the details. It's meant to be something that informs public health guidelines and things, but essentially processed foods is fine. Like processed foods might be like good quality bread, cheese, etc.
Canned corn?
Yeah, absolutely. But ultra-processed is when it was corn once, and it's been taken, it's been cooked, it's been various aspects of it have been extracted, maybe extruded, it's had vitamins and minerals maybe added to it, flavourings, colourings, emulsifiers, artificial sugars, whatever it is. And people think that because the label says, it's low fat or it's low sugar or something like that, or it's got vitamins or minerals or fibre, that it's okay. But actually, our emerging evidence suggests that the body, the gut, the brain interpret it differently.
And so how do people implement that? Because you say Mediterranean style of eating, and maybe this is for you, Tatiana. What are some practical tweaks that someone could make today to adhere to this style of eating?
So in general, we understand that Mediterranean diet, it's all about joyful consumption of various food. And that's what we need to think about. We need to think about what we can add to our everyday eating. So one thing we want people to remember, that we're not talking about restrictions. We need to start with additions. So think about what you might enjoy a little bit more today. Do you like fruit? Fantastic. Eat a bit more fruit. You enjoy vegetables? Look, we all like some vegetables. Eat more of them and see how you go, how it makes you feel. Usually it feels pretty good. And that's what helps us on our road to build this motivation, to build this self-efficacy, to continue making changes. We see from research that even small changes can bring significant difference to how we feel.
So there's the brain benefit that, the way we eat can impact our mood, our brain. But there's often the added benefit too, isn't there, in terms of physical stuff?
Yeah, of course. And, the Royal Australian New Zealand College of Psychiatry, they were the first peak body in the world to release their updated clinical guidelines for treating mood disorders. And they put what is essentially lifestyle medicine as the foundation. Diet, movement, sleep, substance cessation, but they call it foundational. And I think that that's the key. If you get those foundations right, then whether it's a physical disease, whether it's an emotional problem, everything is going to work better.
So how do we implement it? Because this research has essentially looked at dietary patterns, found that it can potentially help mood symptoms in depression. Is this in the absence of medication, psychological interventions, or is it alongside?
Alongside. So the SMILES trial that we led, which is the first randomised controlled trial, using diet to treat moderate to severe major depressive disorder. Like very often people have been very sick for a long time. But the people in that trial were on largely other medications, psychotherapy, these sorts of things. So most of the evidence in this area of nutritional psychiatry has shown that it's definitely not an either or, it's a plus. What we did do too just recently is publish the results of the CALM trial. Now, this is very important because what we did, this is called a non-inferiority trial. So we weren't seeing if one thing was better than the other, But we randomly assigned people with elevated depressive symptoms to receive either group therapy from dietitians, exercise physiologists in lifestyle, how to improve these things. And the other group got gold standard psychotherapy delivered by clinical psychologists. And we found that both were equally effective.
Wow.
Which is excellent because it just gives us more avenues to support people in treatment, and it's also give people choice. Because look, maybe not everyone is ready, willing, or can change their diet right now. So we can review other ways of improving the way we take care of our body.
So what do we know then, Tatiana, about the best way to implement dietary pattern interventions for patients?
As I mentioned before, we talk about adding stuff in, not removing stuff out. We also talk about reducing that decision fatigue, particularly for people living, under some kind of mental health disorder or anything else. Look, we're all busy, so
very busy,
why
yes.
complicate life? So this is why we ask practitioners to provide people with some kind of tools or printout, something very basic and simple, which shows that you don't need 50-ingredient ragu every night, to bring the vegetables in. There's a simple, frozen veggies, canned goods, pre-prepared meals. There's enough option to help us take care of our body.
Felice, this might be for you. Why does what we eat impact mood and brain?
Well, if you think about diet, food is really the petrol that drives pretty much every aspect of our functioning in our body and brain. When we eat, it influences a whole lot of pathways that also really interact with our mental health. So things like our immune system is very, very important, and something called inflammation. Now, that's key. That's definitely involved in mental health. The way our genes work and express themselves, so epigenetics, our stress response system, the mitochondria that live in our cells, the way we produce neurotransmitters, all of these things are influenced by diet and in turn influence our mental health. But the really big one that we focus on now is the human gut microbiome, because that actually affects all those other things. So 70% of our immune system is really in our gut, and the gut microbes, their main role is to digest the bits of food that our human enzymes can't digest. And that's primarily complex carbohydrate, fibre, different types of fibres, but also things like polyphenols you would have heard of. And when they do that, they produce thousands of molecules. And these molecules, they influence the way our genes express themselves. They very powerfully influence our immune system. The level of serotonin in the brain is influenced by how the gut breaks down tryptophan, for example. So the gut is very, very quickly affected by what we eat. And in turn, it very quickly affects our physiology from top to toe.
It's so fascinating, isn't it, how complex it all is. What more do we need to find out?
Look, with science you can go forever and you can dig very deeply. What I'm very, very focused on now is how planetary health interacts with human health via the microbes, because the microbes in the soil are a very important aspect of nutrition in food. So when you have microbially really active soil, you get vegetables and plants that are much higher in nutrient density and much higher in what is known as nutritional dark matter. So these are the phytochemicals. Now, we know about 8,000 of them. This is like the polyphenols, flavonols. People know them as antioxidants.
Okay.
But there may be as many as 150,000 of these.
Or more.
And we don't know what they do, how they interact with receptors in our body. And then you've got, of course, macro and micronutrients all together in the complex package of a food matrix. And this is why you don't want ultra-processed foods, because they don't have any of that complexity. But I do want to just say one thing so we don't run out of time. If you look at all the observational evidence around the world, so that's not experiments, it's just looking at what people eat, taking into account things like their socioeconomic circumstances and, all sorts of other things, and look at the risk for depression, we see that it's reduced in people who have better quality diets with more whole foods and less of those ultra-processed foods. This is completely independent of body weight. And this is the big issue around food for the last 20 or so years, is it all focuses on obesity, as if body weight equals health and it's the only thing that matters. Now, this is actually not true. We need to stop thinking about the way people look and focus much more on how we nurture ourselves, how we feed our body, our brain, our gut to be happy and healthy and have a wonderful relationship with beautiful, real, local food.
That was Felice Jacka, who is a Distinguished Professor of Nutritional Psychiatry and founder and director of the Food and Mood Centre, and Dr. Tetiana Rox, who's the lead of the Food and Mood Academy.
On Radio National, you're with the Health Report.
Coming up, I'm sure many Health Report listeners want to know what their cardiovascular risk is, but once you know, what do you do with the information? We'll be getting into that very soon, but first, Norman, you found out a little bit more interesting stuff around joint replacements.
Yeah, really fascinating study where they basically had people who were going through blood tests and they were having lumbar punctures at the same time for other reasons. So they were taking cerebrospinal fluid off these people and blood. And they had people who had not had a joint replacement and they had people who'd had a joint replacement. And what they analysed the blood and the cerebrospinal fluid for was metals. To see whether or not metals were getting into the blood and from the blood into the cerebrospinal fluid, and if it's in the cerebrospinal fluid, in theory, that could be getting into the brain. Now, we're lucky in Australia. We have one of the world's leading registries of joint replacements. It's called the National Joint Replacement Registry. And in fact, the Australian registry has been the first in the world to signal problems with joints. One was a particular joint where there was a problem with metal. So I spoke to Paul Smith, who actually is clinical director of the Australian National Joint Replacement Registry, and he's recently resigned from his public hospital position at Canberra Hospital, and you'll find out why. But let's start on the joint replacement story.
You're quite right that this was a major issue. The device is something called the ASR hip replacement. The Australian Joint Replacement Registry was able to identify this particular device as having an unexpectedly high revision risk.
It was failing and needed to be replaced.
That's right.
But if I remember rightly, the other problem with that joint was that the metal was getting into people's bodies.
I mean, joint replacements move. Anything that articulates surface on surface will produce a degree of wear. And unfortunately, this particular metal versus metal joint replacement was of a particular design which made it more likely to wear. Metal versus metal wear debris was produced. And these are tiny little nanoparticulates, and you get enormous numbers of nanoparticulates. But along with that, metal ions are released in high concentration, both in the joint and then make their way, of course, into the bloodstream and throughout the body in all tissues.
And when you say ions, people haven't forgotten their high school chemistry. We're talking about charged particles of metal which make them more likely to join with other chemicals and become more reactive in the body. So let's go to this study. They say it was the pilot study, German study, comparing people's blood and cerebrospinal fluid in people who were having a lumbar puncture anyway, and comparing people who had an artificial joint with people who didn't. And they found what on the surface looks like quite disturbing levels of various metals, many of them getting into the cerebrospinal fluid and presumably into the brain. One of them particularly could be quite toxic to the brain, which is cobalt. What's your take on this study?
What you said was correct. This is a pilot study and it's a cross-sectional study.
Meaning it's taken at a point in time.
Because it's a snapshot, you have to be very careful in how to interpret this. You're quite right, cobalt is probably the one of concern because cobalt in high concentrations is cytotoxic.
In other words, toxic to cells.
Indeed. And things like titanium, for instance, are incredibly biocompatible and really non-toxic. You can grow cells on titanium and they're quite happy. Cobalt's a different story.
Give me a sense of the risk here, because they're talking about large joints, so presumably they're talking about knees and hips. Are there particularly high-risk joints?
It's pretty well metal-on-metal articulations which are the issue. Current generation joint replacements are really either metal on plastic or ceramic on plastic or ceramic on ceramic. One of the things that came out of the Australian Joint Replacement Registry, essentially notifying the world this was a real problem, is that metal-on-metal joint replacements have really been extinguished in the joint replacement market. But current generation plastics are incredibly wear resistant.
The National Joint Replacement Registry really is focused on the performance of the joints. But have there been any longitudinal studies of people with joint replacements and the incidence of, say, Alzheimer's disease and dementia? Because Alzheimer's disease, one of the theories is it could be heavy metals starting off the process.
Well, really, no, there have not been high-quality longitudinal studies. The Mayo Clinic has done a cross-sectional study looking at the association between MRI brain changes and cognitive testing in people who have joint replacements versus people who don't. And really, there's no difference at all. And in fact, some of the MRI changes were actually thought to be slightly better in the joint replaced group than the not. So,
because we're getting out and about a bit more and getting more exercise. In summary, then, you're saying the evidence is not there for people to panic and if they've got an old joint in, having it taken out and replaced with a new joint. But people now having joints put in, and if we've had it in for the last few years, your joint's going to be okay because it's either ceramic or plastic. The metal is not there.
Yeah, so much lower risk in today's world. And Australia has one of the most stringent regulatory environments in the world. And we have an excellent surveillance mechanism in our National Joint Registry, which gives people confidence in the technology that's being used.
I want to change subject now briefly, Paul. I'm speaking to Paul Smith, Professor of Orthopaedic Surgery at the Australian National University. About a month ago, you resigned your position in the public hospital in Canberra Hospital, along with, I think, 2 other orthopaedic surgeons. And in the light of the strike in New South Wales in the public system, which they say is much more about the quality of the public system and protecting it rather than money, can you just bring the two together? I mean, first of all, why did you resign? And secondly, is it the same mood in Canberra as in New South Wales, worries about the public system?
I think the two issues are different. So in New South Wales, the strike that's happened is with the junior medical officers. The junior medical officers are stuck in a system where there's chronic understaffing, and so people are forced to work shifts, 16 plus hours, which in today's world is a bit silly. Back in back when the earth was flat and I was an intern, was kind of thought to be the thing, but really it's not particularly safe practice. And also, I think they've got a fair point. Their remuneration is 30% less than other states around Australia, and that has been actually capped for 12 years, and that's why they're in a situation where enough is enough, if you ask me. So I think that a lot of their work conditions are driving this, but also you can't divorce the fact that they're being comparatively underpaid compared to their peers elsewhere.
So why did you resign?
Fortunately, I'm better off financially if I don't work in the public system, so it's clearly not about money. What I resigned about was the attitude of the administration in disenfranchising the clinicians and the interference by management in clinical decision-making.
Can you give me an example?
The decision on clinical prioritisation is made by the responsible clinician.
So somebody's on a waiting list, whereabouts are they on a priority for that, as an example?
Precisely. So these things can be more or less objectively measured, but you also consider those issues in the light of a patient's domestic situation and the effect of their illness on the carer environment around them, etc. And so prioritisation is a person-by-person decision. People are not a number. As far as the administrative attitude was, people are just a number. It doesn't matter what their disease severity or whatever is, we're going to take over prioritisation and management of where that person sits on a particular waiting list. Now, this also applies to the issue of how to manage acute trauma.
So somebody comes in with a fractured hip, for example,
and obviously needs urgent surgery and should be prioritised over someone who has a low acuity issue, such as an elective procedure. Quite rightly, the person with trauma should take priority. And this is something that the administration, for some reason, think, the person with elective on the elective list should take priority over someone with trauma. Hang on a minute, that's just not quite right, is it?
And what does the administration say to your critique? What's been a response to your resignation?
In a word, I got an email saying, thank you for letting us know.
You're kidding. And it has to be said that it's not as if Canberra has a surfeit of specialists in the public sector.
That's the sad bit. It's not exactly the Mayo Clinic of the Southern Hemisphere. And trying to attract high-quality, committed individuals who are going to provide great service into the public sector is a real challenge. And if the administration is a hostile one, then obviously recruitment is absolutely torpedoed. And sadly, we've had now, as a result of the administration's, it's almost an aggressive attitude versus the clinician groups.
So now their waiting lists that we're trying to get down are going to go up because you get 3 surgeons not operating.
Well, we've actually got 6 resignations, Norman, so it's not trivial, and that's almost half of our department have attended their resignations.
Paul Smith, who's Professor of Orthopaedic Surgery at the Australian National University and Director of the Australian National Joint Replacement Registry. We've put these points to ACT Health, and we will put that response on our website or talk about it in next week's show. At the time of the resignations, the ACT Health Minister, Rachel Stephen-Smith, denied the claims that frontline health staff were being overruled on decisions about patient care. She said that clinicians were consulted and argued that we as a hospital system have to be fair to all patients, and they were putting in a process, an escalation process for doctors.
On Radio National, you're with the Health Report.
So let's go to the heart and assessing what your risk might be of a heart attack or stroke over the next few years.
Which is something I think a lot of people want to know. And there's a lot of chat about CT calcium scores, which is the CT scan which looks at the amount of plaque or calcium inside the walls of your heart's arteries.
Well, it's been out for a while. I mean, I think I first did a story on this 15 or 20 years ago.
Back in the day.
Where cardiologists were saying there's no point in doing these calcium scores because you could drop dead after walking out and being given the all clear.
So, look, there are some people who should be considering having this score done, which we're going to get into, but there is new research that's been published in the Journal of the American Medical Association, which has looked at people with no heart disease, but a strong family history of premature heart disease, and put some people into a group where they get normal care, risk factor management for heart disease, so move a bit more, eat some more rainbows, and the other group got a calcium score guided care. And what they found in this particular study is that for the people who had the calcium score done, had a chat, were given a statin, the plaque didn't progress as much, and they had better cholesterol control. Now, the question is, who should be having this calcium score done? Who should be having a risk calculator done with their GP like me, or doing it online at home? There's so many questions here, but people want the information. And so I spoke to Professor David Peris, who's the Chief Scientist of the George Institute for Global Health, to find out exactly those things.
When we look at risk of heart disease and stroke, we try to take a comprehensive look at that, look at all your risk factors, your age, gender, blood pressure, cholesterol, etc. People will then use a risk prediction equation to come up with a score, and that risk score will put you into a low, intermediate, or high risk category. It's the people in the intermediate risk who are thinking, what should I do about this? Should I get more intensive treatment and maybe even consider medication? Or should I just work on my lifestyle risk factors, where a coronary artery calcium score might be useful? And obviously, if the score is high, that might tip you into making more active decisions about treatment in discussion with your doctor. Or if your score comes out low, that might be reassuring to you, and you might work harder on your lifestyle risk factors and review that maybe in a few years with your doctor.
So you've just mentioned the risk prediction equation, which is that Australian cardiovascular risk calculator that's used often in general practice. How often does that underestimate or overestimate risk? I guess the question is, how reliable is that really for most people?
Yeah, it's firstly, who should use the risk prediction equation and who shouldn't. The biggest risk factor for a heart attack or stroke is if you've already had a heart attack or stroke previously. So that group of people, they already know that they're at high risk and don't need to go through risk prediction equations or indeed coronary calcium scores. There's also some other groups that are higher risk where the equation's not recommended. People with genetic high cholesterol or familial hypercholesterolemia, and people with moderate to severe chronic kidney disease. These are groups that we know are at higher risk, and it really doesn't add any value to do a risk prediction equation. For everyone else, the equation is recommended, particularly from the age of around 40 to 45. It's worth thinking about doing this risk prediction equation.
What if someone's low risk on the risk prediction equation, David, and says, but I really want to get that calcium score done? What's the potential harm there?
The harms aren't great. It's a low dose of radiation exposure to have the test done. The bigger thing is it's not covered on Medicare. So people having a coronary artery calcium need to know that they're going to be paying the full cost for the test. And it's worth shopping around to find the best price. It can range, but probably around at $200 is the going cost for getting a score done. It's not recommended in people at low risk. If you do the risk prediction equation on cvdcheck.org.au and come out low risk, it probably isn't going to add a lot of value. But you're right. If someone's very anxious and they really want to know, they're aware of the costs of that low dose of radiation exposure, then it could be done. But again, I'd recommend having that more detailed discussion with your doctor. It's really that next group up, the people in the intermediate risk category, where coronary artery calcium testing might come into play.
There's some discussion, David, that perhaps people seeing the calcium score, the numbers, the images actually potentially drives motivation to change lifestyle factors. Do you think that's possibly a factor, that it actually drives motivation?
It can be for some people. I mean, I think for others, it can actually also create undue concern. For some people who are particularly on the edge of thinking about medication, blood pressure medication, cholesterol medicines, and they're just not quite sure whether this is a good idea or not, perhaps in that group where they've come out at intermediate risk, they may say, right, this is actually really important for me, and having in discussion with their doctor say, I want to go on to treatment. And this is lifelong medicine, usually cholesterol medicine and blood pressure medicine. So it's not a straightforward decision. And maybe this information is enough to influence decision making. But I would say it's one of many factors that you would bring into the conversation.
And can we just talk about CT coronary angiograms as well? Because this is something people would have heard of, all these different tests that can look at, further assess your heart disease risk. Where does that fit into this with calcium scores as well?
Yeah, that's a great question. So a CT coronary angiogram is quite a different set of indications. This is for people where you've got suspicion of coronary artery disease, either because they've come in with symptoms or they've got some other risks that have put them into a high-risk category. And this gives you very detailed imaging of the coronary arteries and whether there's plaque there. A CT angiogram would be a follow-up test in people that are already thought to be at high risk.
So is it fair to say, David, that for most of us, the risk prediction equation is adequate? If we fall into that intermediate risk group, then it might be worth considering a calcium score to further stratify exactly where we sit.
That's right. And a calcium score that comes back 0, that would be quite reassuring. That's essentially saying there's no calcium deposited in your coronary arteries, and that might give you the confidence to work hard on your lifestyle factors. And then for the group that where the score comes back high, particularly above 100, that's the group where you want to have a much more detailed discussion around more intensively managing your risk factors.
That was Professor David Perris, Chief Scientist for the George Institute for Global Health.
What have we got in the mailbag, Priya?
Well, it's related to your vocal cord dysfunction story.
Not my vocal cord dysfunction.
Not yours,
right at the moment.
although you sound like you may have it.
It's last week. So it's people, this is a story about a misdiagnosis often, where people get breathless, often misdiagnosed with asthma. They can lose their voice with it, and it turns out that it's the vocal cords that have got the problem.
Yes, and so this is Kathy who's written in. Kathy's a GP who's found an interesting article on Medscape with an explanation of why this might occur after COVID-19 infection, suggesting that COVID may actually impact the nerves somehow, and the vagus nerve as well, which controls cough.
Yeah, and therefore breathing and that sort of thing. Thanks for that feedback, Kathy. Yet another thing to worry about after COVID, but
yes.
You shouldn't worry about it, because at this time of year, not only should you be having the flu vax, but you should be having your annual COVID vax as well. We've also had some feedback on a conversation we had last week, which was new research, which showed evidence from the United Kingdom, both Wales and England, if you were on the shingles vaccine, and it was the old shingles vaccine, seemed to reduce the risk of dementia by about 3 or 4% overall. And I mean, really, to summarize the question is, what happens if you've been vaccinated for chickenpox? Does that reduce the risk later and prevent the need for the vaccine? When the evidence is out there, nobody knows what the effect of chickenpox vaccine in childhood is going to be on shingles 50 years later. And so the advice is that you have the shingles vaccine. You don't agonise on this.
Don't agonise, still get the vaccine. And it's worth mentioning that, yes, chickenpox vaccination is on the schedule for kids at 18 months. That single dose provides about 82% protection against any form of chickenpox. But I often talk to patients about paying for a second dose, and lots of patients will do it. I've done it for my kids. That takes the level of protection to about 98% against any chickenpox, and you're paying about $60 for that vaccine. But you can still get breakthrough chickenpox infection if you've had a single dose, which means you could be at risk of shingles still. If you want to write into us, because we always love chitty-chatting about the mail, healthreport@abc.net.au.
And don't forget our sister podcast, What's That Rash? And this week it's How Worried Should You Be About Micro and Nanoplastics?
I'm already worried. Should I be more worried?
I'm not going to tell you. You're going to
Okay, just listen.
Find out.
I thought there were some perks to this job. Never mind.
Yeah, just eat your Mediterranean diet. Ting, and
Yes.
have a listen.
See you next week.
See you then.
You've been listening to an ABC podcast. Discover more great ABC podcasts, live radio, and exclusives on the ABC Listen app.